So Dr. Maria Gaughan studied in University College Dublin, graduating in medicine in 2010. She completed her neurology training in 2019, having trained in Beaumont, St James's, CUH and the National Hospital for Neurology and Neurosurgery in London. Dr. Gaughan was the Newman Fellow in MS in St Vincent's University Hospital from 2018 to 2022 and is currently completing an Aspire Fellowship. So I will hand over to you, Dr. Gaughan.
Thanks very much, Aoife, for the opportunity to present today. This is a little bit different from some of the presentations we've done with the National MS Conference in the past, but I welcome everyone to this talk. I'm going to give an overview, and I'm very conscious that can't possibly address, I suppose, every individual case, but I would welcome questions and discussion towards the end. This is probably an area in MS that is only recently getting a little bit more focus in how we can optimize the experience for women and looking at what evidence we have. And unfortunately, the evidence we have isn't entirely comprehensive in some particular areas of MS and pregnancy. But overall, what I want to emphasize is that we encourage any women with MS who want to become pregnant to do so. You might need to do a little bit more planning and preparation than someone who doesn't have MS. But if you don't have the opportunity to do that, as a lot of people don't, again, not to worry about that. And that we would aim for MS to have as little impact as possible on your pregnancy and your delivery and postpartum period and the enjoyment that you're going to get out of having your child. So MS is, as we know, more common in women, and I think that's reflected in the number of people that we have attending today. It's commonly diagnosed in young women, and it's commonly diagnosed at a time in our lives when we're considering planning a family. And it can impact family planning for several reasons. So maybe MS has had a bit of a physical impact on you and you're worried about how you can cope. Maybe you've had to temporarily stop working because of the impact of MS and you're concerned about the financial impact of pregnancy. MS, when you're diagnosed, it can be a very stressful and emotional time, and you might want to give yourself a bit of mental space before you consider having a family. And the diagnosis of MS can come around the time that you might be meeting a partner for the first time, embarking on a serious relationship. And it can have an impact on that side of things as well. So what do people with MS think about family planning? And this was a global patient survey that was done, and just over half found that MS had affected family planning. So for some people, the time of diagnosis comes when they've already completed their family. Does it significantly impact their plans for having children? Yes, and for a small number of people, they can decide against having children. That's rarely, in my experience of discussing with people, MS is rarely the sole reason for deciding not to have children, but it can weigh and it can push people perhaps one way or another. People might delay plans for having children. I think that 7% number is a little bit low, and in fact I think probably it's a little bit higher, because I think if you have MS, as I've already alluded to, you might think a little bit more about it, and that ultimately can result in having a little delay. And only a small number said that it has minimal or no impact on family planning. So some of the worries that people might have include in relation to contraception. Does pregnancy bring on MS or make MS worse? What preparation can you do for pregnancy? Is there any preparation you need to do for pregnancy? What about if you're on medication? Will that impact on things? Then you might have heard some rumors about delivering the baby. Will it have any impact on that? And then what about breastfeeding after the baby is born? I'll also mention fertility treatment briefly and discuss what we know and what we don't know in relation to that. So I suppose one of the things that's changed a lot over the last 10 to 15 years is that in the past, a lot of people who were considering pregnancy and multiple sclerosis may not have been on a disease-modifying treatment, whereas now the majority of people are on a disease-modifying treatment, and we would recommend overall being on a disease-modifying treatment from diagnosis, from the time of diagnosis, and the evidence suggests that that's really the best thing for most people to do. And we don't have exact figures for Ireland, but I think that our figures have probably been most closely reflected in the figures from Northern Ireland, where a majority of people after diagnosis commence a disease-modifying treatment. And that can be a concern for both the clinician and the person with multiple sclerosis if they're thinking about planning a family. And in some medications, there are quite strict instructions regarding family planning and the need for contraception. So what about contraception and what about fertility? So is there any form of contraception you should or shouldn't use? Are there any risks from contraception? Is hormonal contraception associated with multiple sclerosis? And will contraception interact with my disease-modifying treatment? So we're going to try and answer some of these questions now. So the type of contraception that you use really depends on multiple different things. And one of them would be is how sure do you want to be that you're not going to have a pregnancy? So some people are using different forms of contraception, but if they did become pregnant, it wouldn't be to them the end of the world, and they're aware of that. Whereas for some people, becoming pregnant would be something they would absolutely want to rule out under all circumstances where possible at all. When contraception is being studied about how effective it is, they look at it in two different ways. And one of it's if you use contraception absolutely perfectly, how effective is it? And if you use it the way that most people use it, how effective is it? And when we consider how most people use contraception, probably the more effective forms of contraception would be a lot of the long-acting forms of contraception. So that can include things like the copper coil, the Mirena coil, and what's commonly known as the bar that you can see there in the palm of the hand. How long do you want to use the contraception for? So are you thinking about having a family in the next year or two? Or is it something that you're not thinking about for much longer? Is it something that might be 5, 10, 15 years in your future? If you have, so the only, I suppose, concern about MS in relation to contraception would be that if you have some disability related to your multiple sclerosis and that you have long periods of immobility, it's probably a good idea to avoid the combined oral contraceptive pill, which is kind of the main pill that a lot of people are prescribed, and that would be because of the risk of clotting associated with it. So you'd have another risk factor because of prolonged mobility. But other forms of contraception, including the progesterone-only pill, would be available to you. What access do you have to the best form of contraception? So again, with the combined oral contraceptive pill, there are some restrictions. So if you're a smoker and if you're over the age of 40, this form of contraception isn't really recommended for you. So you might have to look at one of the other forms of contraception in conjunction with your GP or your healthcare provider. Are there any drug interactions? So basically not with the disease-modifying treatments. However, some of the symptomatic treatments that you might be on, for example, some people might be on modafinil for fatigue. And because of the way that modafinil works, it might slightly reduce the efficacy of the combined oral contraceptive pill. With a lot of medications like this, when we say things like reducing the efficacy, we don't know how much and we don't know what the impact is, but that is something to bear in mind if pregnancy is something that you're absolutely hoping to avoid. When you're considering things like some of the medications, so some people here might be on cladribine, Mavenclad, for example, and as you know, contraception is recommended quite forcefully when you're on this medication. You absolutely should not become pregnant when you're taking cladribine. And they would generally recommend 2 forms of contraception, so that if you're a woman, you'd be using perhaps a oral contraceptive pill, the progesterone-only pill, coil, and if you have a male partner, that they'd be using a form of barrier contraception, perhaps. So there is an increased incidence, as we know, in prevalence of multiple sclerosis over the last 20 or 30 years. And one of the questions that people have been asking is, do we know why that is? And one, I suppose, concern that people had was that in any way related to oral contraceptive use. And 2 large studies attempted to answer that and had slightly contradictory results. So one of them said maybe yes, and one of them said maybe no. But overall, the consensus seems to be that oral contraceptive use is not associated with the risk of developing multiple sclerosis. Interestingly, one study was done where they took a high dose of the oral contraceptive pill with quite a lot of estrogen in it, and they combined it with interferon beta, and they looked to see if that reduced the number of new lesions. And the study wasn't highly significant, but did suggest that actually this might be something that could be explored a little bit further. So another question is, does pregnancy have an impact on MS onset? So one thing I'll say about this is that this doesn't make a difference once you have a diagnosis of MS, or it doesn't seem to make any difference once you've had your first episode. But there have been two large studies that interestingly show that if you have had a pregnancy, or if you have been pregnant, you tend to have your first episode of MS later than if you have never been pregnant. One study, a Swedish study, suggested that it delayed the onset of MS by about 7 years, but a larger study has more recently looked at it and said that it does definitely seem to delay it by about 3.5 years. And again, the question is why that might be the case, and that's something that would definitely need to be explored further. Once MS has been diagnosed, overall, and again, this is, I would say that a lot of the information we'll share now is a very kind of general, and overall, it doesn't make any difference, but that could change on a case-by-case basis. And that's the study that I mentioned showing that delay. So what about infertility and multiple sclerosis? Is this an issue? So the impact on fertility is unclear, and it doesn't seem to have a direct biological impact on fertility for most people. However, women with multiple sclerosis tend to have less children, and there can be multiple reasons for that. One thing, as we mentioned, is that it might delay the time that you're thinking about having a family. And as we know with women, that after the age of 35, it can start to get a little bit more difficult to conceive. So you might have delayed the time period when you try and have a family, and then you might get to that point and realize it's more difficult than you expected. So about 1 in 6 couples experiences infertility anyway. So if you are someone with MS who has difficulty with fertility, it's probably unrelated. But just to be aware of things like delaying things perhaps for that little bit longer. So this was a study that was done where they asked women about their worries in relation to pregnancy and pregnancy planning. And I think that's very useful to get that experience from people, and some people might recognize some of these experiences. So for example, somebody had a lot of fatigue, they've seen their sister experience a pregnancy, and they've seen how tired their sister is managing a new baby, and they're like, how will I manage a new baby on top of my existing fatigue? Then another doctor said, your chances of having a perfectly healthy baby are just like anyone else, because people can be concerned that, well, the MS will have an impact on the pregnancy. Sometimes, I suppose an older idea would be that if you have MS, you can't have an epidural. This again is not the case, but you might hear this misinformation from a medical professional who isn't up to date with the latest data. And then people are worried about what happens if they stop their disease-modifying treatment, or if they have to stop their disease-modifying treatment in pregnancy. I'm going to come back to this again, but I think it's important to remember that you might have had a conversation with your doctor around the time of diagnosis about pregnancy, and that might have been 5 or 10 or 15 years ago, and the information that you were given at the time might actually not be the case any longer. So if it's something on your mind, it's something that you're considering, and do talk to someone again, because information is changing all the time. What we know, what we understand, what we recommend is changing all the time. So if you are considering pregnancy and you have multiple sclerosis, have a chat with your MS team, and people who can be particularly helpful and have probably more time, and often who have a lot of experience in dealing with this, are the MS nurse specialists. If you're on a disease-modifying treatment, so the DMT is a disease-modifying treatment, so that's your MS-related medication. Which one is it? Is it considered safe in pregnancy? So some disease-modifying treatments we would recommend continuing through pregnancy. Some we would recommend discontinuing a couple of months beforehand, and some of them we would recommend continuing right up until you become pregnant and then stopping at that point. Are you on any other medications that might need to be reduced or stopped, such as fatigue or pain medications? Sometimes medications like baclofen might need to be reduced or stopped. Some antidepressants that could be discussed with your GP. Maybe the dose might need to be slightly reduced, but a lot of the time you can continue these medications. Some medications for pain like pregabalin or Neurontin that might need to be reviewed, particularly if you're on higher doses of those medications. And you might need to look at yourself, the timing of when you want to reduce or stop these medications compared to the timing that you're considering conceiving. Maybe have a think about when your last scan was. So it's ideally, which I'll come on to in a second, before you become pregnant, your MS will have been stable for a little while. So have you had a scan recently? A lot of people there, and depending on what hospital you're in, access to imaging can be quite difficult, and COVID might have delayed your scans. You might have had a scan now for 2 or 3 years. So even though you might be quite well, we probably want to make sure that things are going fine from a scan point of view too. Do you need to do anything to prepare for pregnancy, which we'll come on to in a second? And then the worry that a lot of people have is, will pregnancy make my MS worse? And for the vast majority of people, that is not the case. So for the majority of people, pregnancy won't make MS worse. There's the odd person where they might have quite highly active MS. And for those people, in order that we make sure it doesn't make it worse, we might need to make more careful discussions about treatment in pregnancy and treatment after pregnancy. So ideally, MS is stable for a year prior to conceiving. Again, not all pregnancies occur in an ideal world. So if that isn't the case, there's no need to panic. You can just discuss things with your doctor and your nurse specialist. We would often recommend remaining on your disease-modifying treatment or a disease-modifying treatment, depending which one it is. And this is very much a case-by-case decision, but it's becoming increasingly common to remain in the DMT, at least up until conception. Your pregnancy overall, we would like to see it being as normal as possible, and that if you're lucky enough to have a pregnancy that can be enjoyed, that you would enjoy your pregnancy. And that some women with multiple sclerosis do feel better in pregnancy than they normally do. Some people do find that some of their MS symptoms might be aggravated in pregnancy. So say, for example, if you had a little bit of difficulty walking that isn't very prominent, if you're very fatigued in pregnancy, if you're carrying a large baby in the 3rd trimester, you might find that you're a little bit slower again than you would expect. Your symptoms are slightly worse. I would probably recommend, actually, not that I would probably, I would recommend for any woman with multiple sclerosis to try and make an appointment with a women's physiotherapist. So I would probably try and contact them through your maternity hospital in the first instance. And if they can't see you, I would consider trying to make a private appointment. And that would be to look at your pelvic floor health. So women with multiple sclerosis do have difficulties, as we know, with urinary tract infections and sometimes with incontinence. Again, not all women, but some women do. So given that pregnancy can also result in some of these symptoms, we want to make sure that your pelvic floor is as good as it can possibly be, so that we don't aggravate something that's already there. I would also recommend, if you are feeling well in pregnancy, to be as active as you possibly can, to build up your strength if you can during pregnancy, because you're probably going to need it in the postpartum period. And another thing to mention, which I haven't written down there, is that there are a lot of symptoms in pregnancy which might be a little bit triggering or frightening for women with multiple sclerosis, and you might be concerned it's a flare of your MS, but that are actually normal for pregnancy. So symptoms are round ligament pain, which can be a kind of stretching pain in your groin or abdomen. It's very common, particularly in the 1st and 2nd trimester. And it's really just the ligaments around your pelvis starting to stretch and getting more lax to accommodate a growing baby. The lovely term of lightning crotch, which is a sharp shooting pain going down towards your crotch really, and that often occurs later in pregnancy. It's a pretty normal pregnancy symptom, but again could be frightening. Some people might find that if they've any history of sciatica, which is a pain radiating down your glutes and down the back of your leg from your lower back, that might be aggravated by pregnancy. And pelvic girdle pain is also very common in pregnancy. So none of these symptoms would be related to your multiple sclerosis. If you do experience and you are concerned, probably a physiotherapist would be your first port of call to go through things. You can also discuss them with your MS team at any time if you're worried. Because there was a concern, and if we look back decades ago, going back into the 70s and probably even the 80s, some women with multiple sclerosis were advised not to conceive or have pregnancy because of the fear that it was going to make the multiple sclerosis worse. And then this study came out in the 1990s, and Professor Hutchinson, who some of you might know from St. Vincent's Hospital, was involved in this, which demonstrated that overall the risk of relapse in pregnancy reduces slightly in the first and second trimester and goes down to almost zero in the third trimester, with a slight increased risk of having a relapse after the baby is born. However, overall, pregnancy and delivering babies for most women does not result in any more rapid progression of their multiple sclerosis. And then more recently, this study was done and it shows almost exactly the same, which is kind of reassuring. However, being on a disease-modifying treatment before conceiving halves the risk of having a relapse postpartum. So it shows that in the era now where we're using disease-modifying treatment, where the pattern is the same, but the overall risk is much lower of having a relapse, particularly if you've been on a disease-modifying treatment. If you've had a couple of relapses in the year before pregnancy, then there perhaps is a slightly higher risk of relapse after the baby is born, and you might be somebody who might need to get back on a disease-modifying treatment very quickly, or might be somebody that would continue a disease-modifying treatment during pregnancy to reduce the chance of that. About 3 years ago now, the British brought out nice recommendations for how we should manage women who are becoming pregnant, because it's difficult sometimes to collect all the evidence and put it together. And they do recommend that you're not, and I'll come on to this again as well, you're not automatically a high risk pregnancy. So that again, pregnancy should be largely normal. That's what we'd aim for, that's what we should hope for. And you should continue to take your vitamin D during pregnancy, that would be important. Postpartum, and I'm going to talk about this in a bit more detail, breastfeeding is overall a good idea for people with MS, and there is good evidence that exclusive breastfeeding can reduce your chance of having a relapse. They also looked at medication on a case-by-case basis about what we're doing, and some of this medication is slightly different even now, but overall, if you're on one of the injections, one of the older injections which have been around a long time, they're considered very safe in pregnancy and safe in breastfeeding. Some medications, such as people who are on Tecfidera medication, we would now say you can probably continue that up until the time of conception and then discontinue the medication. Medications like fingolimod should probably be washed out. And again, you need to talk to your care provider about that, about how that should be done. And for some women on Tysabri, we recommend continuing right up until the third trimester, as that seems to be the safest thing to do, with a plan to resume the medication in the postpartum period. Medications like cladribine are considered dangerous for the fetus, so you shouldn't become pregnant when you're taking the medication, and you should avoid pregnancy for 6 months after you've had your treatment done. And unlike most medications, this applies to men as well as to women. So pregnancy, the aim is to have a normal pregnancy. You might want to hold off on having a routine MRI. There's no absolute contraindication. If you needed an MRI scan, if you absolutely needed it during pregnancy, then we could do it. But we generally say there's often no need if we've planned things beforehand. You generally don't need your baby to be scanned any more than any other woman who's attending the same hospital as you, who's the same age as you, and there's no known differences in outcome for the baby. You can deliver however you wish to deliver from the point of view of your multiple sclerosis. So if you're keen on a home birth, if you're keen on hospital birth, if you're keen on having a vaginal delivery, if you really want a cesarean section, the MS shouldn't play a significant role in this unless your obstetrician would differ. But from the point of view of your multiple sclerosis, you can deliver however you wish. Urinary tract infections are common enough in women with MS and can be a bit more significant in pregnancy. So keep an eye out for that, and they should be treated pretty promptly. As mentioned already, vitamin D, and you can have any pain relief you wish. You can have an epidural if you want, and that's absolutely fine. There's a lot of hypnobirthing, breathing exercise might be very helpful for you. If you want to try for a delivery without an epidural, there's a lot of online evidence, or even in your hospital antenatal classes, about different movements and different positions that can be helpful, such as showering. Some of the hospitals have the capacity to offer water births, some of them don't. But if you do have some disability, you might find that some of the movements suggested, some of the positions suggested don't work for you. But what they recommend now is trying these out and getting into these positions and practicing these movements before you deliver, and then you can figure out what works well for you. Would recommend for most women, whether you have MS or not, to make a birth plan. And if it's your first pregnancy, that can be a bit daunting, partly because you don't really know what you're supposed to put on it at all. But when you're in labor, you mightn't be able to express what you want or what you've decided that you need. So you mightn't be able to speak up as well, and your birth partner, whoever that is, mightn't feel comfortable in doing so. So if you have things written down in advance about things that you want, so that might be you want an epidural early, or it might be that you'd like to see if you can manage without an epidural, and that you don't want to be offered an epidural unless you ask for an epidural. It might be that you want to try for a water birth if that's an option at your institution. It might be that you're keen for a section. It might be that you want skin to skin immediately. It might be that you want your partner to announce the sex of the baby. There's a lot of different options and possibilities for you to make the birth experience as pleasant as you can possibly have it. So we often focus on the pregnancy and the delivery, and for women in general, but this is particularly important for women with MS, we tend not to focus enough on the postpartum period. And I would encourage you, if you're pregnant or planning to become pregnant, to think about this time as well, not from the point of view of negativity, but just to maybe put a few things in place that might help with that. So what I would encourage you to do is, a lot of the hospitals still have some COVID restrictions in place, and while your partner might have access, they might have to go home at one point in the evening, and there might not be anyone else allowed in. So if you think because of significant fatigue or because of some disability that you're going to struggle in any way with looking after the baby when you're in hospital, I would discuss that in an early stage with the midwife or with your obstetric consultant, and you could discuss having access for the person, or are they going to assign you a healthcare assistant to help you care for the baby if your partner or if nobody else is allowed in, or what is the plan going to be if you need a bit of extra assistance in the hospital after the baby is born. And this is particularly true if you're maybe going to have a cesarean section. You might consider whether your recovery is more likely to be better in hospital or at home. So you might prefer to stay in hospital, particularly if you have a busy house at home, or you might prefer to get home as soon as possible. And if you are getting home as soon as possible, if you think you'll rest better there, if you think you'll have better support there, that most hospitals do have access to early discharge schemes where the midwife will come every day, or public health nurse will come every day for a few days. I would recommend meal planning in advance so that there is some food in the house, and that's something that anyone can bring you. And ask for help. One of the things that happens often when people will offer generically help, but they can often not know specifically what is needed and what you need. So have a think about what you might need. And when someone offers to help, ask if they can do that. So they offer, oh, is there anything I can do? Well, actually, could you pick up some shopping for me? actually, yes, could you take my older son out for a few hours so I get some time alone with the baby? Actually, yes, could you keep an eye on the baby for an hour now just because I want to get a shower or I really need to have a nap, something like that. The public health nurse is there to support you postpartum and do ask questions and do use them. Your GP is also there. There is a slight, and again, I don't want to be negative about this, but I think it's important just to have this in the back of your head, and maybe not just for yourself, but your partner and your family, that people with MS are a little bit more vulnerable to postpartum anxiety and postpartum depression. So again, they're both common anyway, but they might be slightly more common with you, particularly if you have vulnerability to low mood beforehand. So what if you have a history of depression or anxiety, what were the signs beforehand? What might be the signs that you're struggling a little bit in the postpartum period? And have a think now about who you're going to talk to about that if that happens. Are you going to talk to your GP? Are you going to talk to the MS team? Are you going to speak to the public health nurse? And another thing to think about in the postpartum period is, are you thinking about going back on a disease modifying treatment? When are you due back in clinic? When is the first scan? Even if that mapped out before the baby is born, that might be helpful, because often once the baby is there, it can be difficult to make the phone calls, to do the planning, to write things into the calendar. Just to speak briefly about breastfeeding, I think we all know now that breastfeeding is promoted a lot in hospitals. However, often the supports around breastfeeding and the education around breastfeeding isn't quite there or where it should be. And one of the big issues is that for a lot of us, our mothers and grandmothers didn't breastfeed. So there isn't that kind of collective knowledge around breastfeeding that can be helpful and to help answer the questions that you'll have around what's normal or not normal for a breastfed baby. The reason I'm mentioning it here is that there is good evidence to show that exclusive breastfeeding reduces the risk of a relapse postpartum. So if you want to delay for any reason going back on a disease modifying treatment, if you're someone whose risk might be a little bit higher, then exclusive breastfeeding is a good path to take. The evidence, if you're someone who's supplementing with formula, the evidence isn't quite as strong, but there is a tend towards that it's also beneficial, but we can't be as certain about it. What I would do, if then breastfeeding, with that knowledge, if breastfeeding is something that you'd like to do or you'd like to try, again, like everything else, I'd probably talk to somebody beforehand. So most hospitals have a lactation consultant. I would ask to speak to them beforehand about breastfeeding your baby. And the one thing about having multiple sclerosis is that you can be very clear, this is why you need to speak to them and this is why you need a little bit of extra support. I think most hospitals would be accommodating. On top of that, you might look at doing a lot of lactation consultants offer online breastfeeding classes now. On top of that, there's a lot of information in breastfeeding available online, particularly on the likes of Instagram. You don't have to look very hard to find a lot of free information available. And particularly as I know that seeking out lactation consultants and doing courses can be expensive. Most antenatal classes do have a breastfeeding component to them, but it mightn't be quite enough. And part of it is, again, like I mentioned, learning what's normal for a breastfed baby. On top of that, local breastfeeding groups around you can be very helpful in the postpartum period. And La Leche League, I understand if you phone up, will often have someone locally, a peer supported, they will send out to your house to discuss breastfeeding with you, to look at the latch, to make suggestions around positioning. Some of the challenges that people have or that people worry about before they even try breastfeeding are things like fatigue, that they're not going to have enough energy to continue it. However, one of the things about breastfeeding is that there is a bit of a belief that breastfed babies don't sleep as well as bottle-fed babies. And there's mixed evidence about that, but there is some evidence that women breastfeeding sleep longer than women who are bottle feeding. One of the things around that might be is that the breastfed baby might wake more often at night. but they also settle back to sleep more quickly. There's no need to go out of bed. There's no need to go and get a bottle, warm the bottle. A lot of the time, once you've gotten the hang of things, you mightn't even need to sit up, depending on how you're sleeping with the baby. You can feed the baby lying down, and the prolactin involved in breastfeeding can often promote getting back to sleep very quickly for someone who's breastfeeding. Depending on if you have a little bit of disability with your MS, you might have some difficulty with positioning and latching the baby, and you might need a bit of support with that. A lot of women have difficulties with supply, particularly in the early days. That's impacted by stress. If you've had a section, your supply can just be a bit delayed coming in. If you've had a postpartum hemorrhage, your supply can be delayed coming in. If you're not eating enough because you're busy running around looking after the baby and you're not feeding yourself, that can affect the supply and dehydration. You might need to supplement a little bit with formula initially, and sometimes lactation consultants in the hospital recommend using a manual or an electric pump just to kind of stimulate the milk supply coming in. Some disease modifying treatments are compatible with breastfeeding, some are not, but if you are again exclusive breastfeeding for a period of time, that should be in itself protective. So in relation to fertility treatment, what I would say, we don't have enough evidence in relation to this. So as I mentioned earlier, fertility challenges are very common. At the moment, for people who don't have a chronic illness like multiple sclerosis, if you've been trying to conceive for a year and you're under 35, or 6 months if you're over 35, it's recommended that you go in and have some fertility testing done. What I would suggest is that you're somebody with MS and you're discontinuing a disease modifying treatment, you could consider going a little bit quicker than that, and maybe your GP might do some very basic testing, such as your anti-Müllerian hormone, which can be an indicator of your egg reserve. And you could also have, your partner might be able to have some semen analysis done at an early stage. One of the reasons I suggest this for some people is that there's no point coming off a highly active treatment and being off it for up to a year, and then finding out that for that entire time you weren't ovulating at the time you thought you were ovulating at, for example. So you could do a little bit of work around your ovulation times, your AMH, things like that at an earlier stage if things aren't happening quite quickly. Infertility is also commonly considered a women's issue, but there is a significant male factor. So what we know of is about a third related to male factor infertility, a third female factor infertility, and a third, we have absolutely no idea, unfortunately, why. So if you need fertility treatment, is that going to have an impact on your multiple sclerosis? And some data suggests that it might cause things to flare up a little. However, that's based on data for some older protocols that were used in fertility treatment that aren't as commonly used anymore. And it was also based on people discontinuing the disease modifying treatment, which, as we've discussed, not everyone does now, or if they do it for a shorter period of time. One recent study where people use fertility treatment and become pregnant, that seems to be very safe, and there's no risk of relapse with that. So we frequently refer and encourage people to seek fertility treatment where appropriate. May increase the risk of relapse, but the evidence is not strong for that at all. So I would say not to be very concerned about that. We don't know much about disease modifying treatment and fertility treatment. One issue that's come up a few times is where you're looking at IVF, but specifically the egg collection portion of IVF, and no one seems to be able to answer the question in relation to disease modifying treatment and egg collection. However, the way I think about it is the eggs that you're collecting, if you're going for egg harvesting or egg collection, either in isolation because you want to freeze your eggs for later use, or as part of IVF, where later on is going to be an embryo transfer, is just looking at the egg collection. The eggs that you're collecting are there, and they've been there all your life, and they've been exposed to everything you've taken all your life. So it shouldn't make a huge difference if you're on a disease modifying treatment around the time that the eggs are collected. It may, of course, however, make a difference at the time of embryo transfer, but some people, the embryo transfer is not occurring immediately around the time where the egg collection is, but that's just I suppose, quite a niche area, but a question a lot of people have and that we often stumble around answering. But overall, theoretically, it shouldn't make any difference. What I would say, as I've alluded to a few times, is the information around pregnancy and multiple sclerosis and around fertility is constantly changing. And if you were pregnant 6 or 7 years ago, the advice you were given then might no longer apply. The data in relation to disease modifying treatment is changing probably on an annual basis. And even looking at cladribine in pregnancy, whereas we recommend so strongly not to become pregnant on cladribine, the pregnancy outcomes are not as negative as we might have expected given that. So it's not that if you're on cladribine and you become pregnant, there is definitely going to be a problem with the fetus. That is not the case. The UK have just set up in the last year or so a pregnancy registry, and that's really where we need more internationally. We need to get more information from. We don't have one in Ireland at the moment. However, MS Base, and some people might have been asked in their clinic appointments if they're happy to sign up for MS Base. And they can do a pregnancy registry in relation to that some of that data can be used to inform future research, which of course is what we need to know. So I suppose something that I'd like to hear from people as well, and I'm very happy to answer any questions and to engage more in the conversation, is, do you consider family planning to be something that might affect you when you're thinking about disease modifying treatments? Do you routinely discuss family planning with your MS doctor or nurse? So what I try to do in the clinic, I've been away from the clinic for a while now, but what I try to do in the clinic is, if I see somebody who's of childbearing age, very quickly throw it out in the clinic appointment. Are you thinking about having a family in the next year or two? Are you thinking about any future pregnancies? Is there anything you want to run by me? Because ideally, we'd have that conversation a year or so before somebody's planning, so we can just go through a few recommendations, or so we can address any concerns or dispel any myths. If you've been pregnant, what's worked well for you in pregnancy in relation to your MS, or what hasn't worked for you? And if you've been pregnant, have you found that MS has made things more challenging at an already challenging time? So that's me finished now, and again, I'm very happy to answer any questions that anyone might have, and I'll stop sharing there.
And thank you very much. And there's so much to take in that presentation, so much fantastic information. And the fact that this session is recorded and is going to be available on the website afterwards, it's just going to be such a fantastic resource for people to be able to go to at any point to kind of recap on that, because while it may not be something somebody's really considering in a very detailed way now, they'll know it's there, and that's wonderful. We do have lots of questions, to be fair, coming in, Maria, and again, lots of praise as well for your presentation. It was absolutely fantastic. So we might just get stuck into the questions then, if that's okay. Wonderful. So one of them was, if you've got progressive MS and you want to have a baby, like what is the situation with that?
So there's no evidence that it should make things go any faster. But if you've got progressive MS, what I would say is you probably have some disability that you've noticed, and that you might find that things are a little bit more difficult from that point of view when you're pregnant or in the postpartum period. So you might have to plan around things a little bit more carefully. So maybe you have a bit of spasticity and you're on baclofen. So maybe if you're in labor, then you might have difficulty in holding a position for a long period of time. You might have to move more freely. An epidural might be a better option for you, or it might not be a better option for you. But I think these things would need to be explored a little bit more. You might need to talk to your obstetric team about if you need something like baclofen around the time of delivery. Will that have any impact on the baby? Can you have it? What kind of times can you have it? So you might need to think about things like that. In the postpartum period, if you have progressive MS, again, if you have any difficulties with your ability, if you have any little bit of disability, how does it affect you? So is it walking that you're affected? Is it that maybe one hand isn't quite as good at the other hand? Are you going to have a little bit of difficulty with feeding the baby? And discussing that at an early stage as you possibly can, so that you're confident you're going, okay. And I do see this with you. There's a lot of women who have different conditions that can affect their mobility, can affect their hand function, that cope extremely well and cope independently, but they might just need a little bit of planning and support around it. So you might find, if you're progressive MS and you're breastfeeding, that you can't sit in certain positions for any kind of long period of time because it's not comfortable, it's not possible, you can't support the baby in the same way. So you should meet your lactation consultant beforehand and explore what would be the best options for you, so things like that. So it's more around the planning and exploring and the difficulty. Again, if fatigue is a huge issue for you with your progressive MS, what support can you put in place for the postpartum period? What support can you have in the hospital? If you've progressed MS in the hospital, I would absolutely go to the hospital and say, look, I think I'm going to need a bit more help when I'm in hospital for those couple of days after I deliver. Is there a healthcare assistant, or are you going to let my partner stay all the time? Or can I bring in another relative to help out with that if I need? You might plan to have a relative staying for a week or two in the postpartum period to support you and your partner. If you have a partner and your partner is going back to work after the 2 weeks maternity leave, then maybe somebody might come and stay for a little while to help with that. But you can absolutely go ahead and achieve pregnancy and plan a pregnancy with progressive multiple sclerosis. That's fine, and that can be done. It just might require a little bit more preparation if you have as good as you possibly can.
Thank you. And there's a question here, Maria, about should males with MS consider discontinuing DMTs when trying to conceive with their partner, or is this dependent on the medication?
It's totally dependent on the medication. That's an issue is cladribine. So if you are on cladribine, then, and you're a man, you overall shouldn't conceive with your partner when you're on the cladribine medication until you've had 6 months after you've completed the medication. Then you could conceive with your partner to make sure there's no trace of the medication in your system. Again, if you have accidentally conceived with your partner unexpectedly, as happens all the time, there's not necessarily any need for panic, particularly if it's the male partner is on the cladribine. But cladribine is the only real one. I mean, if you're on natalizumab, fingolimod, if you're on Tecfidera, if you're on any of the interferons, if you're on ocrelizumab, it's absolutely no concern at all for the male partner.
Thank you. There's a question then from a qualified midwife, and she said, I'm presuming, they give talks from time to time on student midwives about looking after women with MS in pregnancy, labour, and in the postpartum period. They've read recent systematic reviews that suggest women who exclusively breastfeed are less likely to relapse in the first 2 months post-delivery. With that in mind, what treatment options in terms of DMTs are safe for women to use in the postpartum period? Is it only glutathione acetate, or are there others that may be suitable?
Well, firstly, I'm delighted to hear that that student midwives are getting education specifically in care for women with MS and pregnancy, labour, and postpartum period. I mean, that's brilliant. And that's actually the review I was referring to there, that it's exclusive breastfeeding does look like it's definitely protective, and therefore, as much as possible, women with MS should be strongly supported. I don't want to say encouraged, because a lot of the time people want to breastfeed, but they run into challenges and they don't have enough support when they run into those challenges, and so they don't know how to continue. But I would say strongly supported to exclusively breastfeed. So what does that mean? So that means that before women go in to have a baby, they know that on the second night after the baby is born, the baby is going to be up all night on your chest, cluster feeding, and that has a purpose. It's not because the baby is starving and the baby probably is a bit hungry. The purpose of that is to bring in your milk supply, and that will bring in your milk supply. And because the baby's doing that on night 2 does not mean the baby's going to be doing that forever. But it does mean that the following day you're going to need somebody to take the baby for a while to get some sleep. But that's normal. Women also need to know that it's normal for an exclusively breastfed baby to lose a little bit of weight in the postpartum period, and that can be okay. The 10% is considered the magic number all the time about supplementing. You may or may not need to supplement. Things that can promote bringing in your supply as quickly as possible. And your supply, the other thing is your supply won't come in for 3 days. So if the baby isn't getting much milk the first couple of days, that again is entirely, completely normal. That is totally normal, and not to panic about that. You might want to consider antenatal colostrum expressing. So that's where you basically manually express a bit of colostrum before the baby's born. And you can have that in a syringe, you can have that in the freezer. You have to only get a few mils, but it's a little bit extra to give the baby while your supply is coming in. And I think even doing that can give women the confidence to know their body, to understand the body, and give a bit more confidence in breastfeeding. So that's just to start off with the breastfeeding side of things, from the point of view of what DMTs are safe. So any of the interferons of glutathione or acetate are considered safe in breastfeeding. However, those medications usually take a few months to become effective. So you might be better exclusively breastfeeding for a period of time and then going back on another medication, such as, for example, Tecfidera. If you've more highly active MS, for example, or have had a couple of relapses prior to becoming pregnant, or maybe even you might have been unfortunate enough to have a relapse in pregnancy, then something like Tysabri is a very good medication option. And while we can't say it's absolutely safe in breastfeeding, it's probably fine. And some women are breastfeeding pretty confidently on Tysabri without any issues for the baby at all. And you would probably be on the 6-week interval with Tysabri, again, which would again reduce the risk of anything getting through to the baby at all. But so that's probably what we'd recommend. Is that okay?
Yeah.
Any other questions about anything?
Yeah, we have a good few questions. Somebody's just wondering, they said excellent thanks for the presentation. And on the slide about medication for ocrelizumab, what does the 12 out of 12 mean?
I think, let me just have a quick look back, but I think that might refer to 12 months off the medication before. Sometimes I'm loath to discuss things like this in a broader term, because that evidence is kind of changing. Yeah, I say it means avoid pregnancy for 12 months. So
okay,
I'm not sure if it's changed yet, but I think they're planning on changing that license to 6 months. And on rituximab, which is a very similar medication to ocrelizumab, the license is wait 6 months until you become pregnant. Some MS experts in pregnancy who practice in Europe and who do this work all the time don't even wait 6 months. They go a lot quicker. The official license from the company says 12 months, but like I said, ocrelizumab says 6 months, and some clinicians who practice in this area on a very regular basis say an even shorter time than that. So I would discuss that with your medical team, as that isn't necessarily a strict rule at all.
Great, thank you. Somebody has asked if the physical pressure during delivery can worsen MS.
So generally, no. However, yeah, so no is the overall answer to that. But during delivery, a lot of women might tear, or might have problems afterwards with their pelvic floor. And if you have, as I mentioned in the talk, issues related to continence already, or if you have a heaviness in your legs from MS, you might have a little bit of subtle stiffness in your legs that is fine most of the time, but sometimes for a while your legs feel heavy. If you get a prolapse, that leads to an awful feeling of heaviness in your pelvis. And if you already have heaviness in your legs, you will just feel worse overall. So it doesn't make your MS worse, but you might feel a little bit worse if you develop these symptoms after having a baby and after having a vaginal delivery. And that's why I recommend as much as possible seeing a pelvic health physiotherapist beforehand. And there's a lot of good information online now about having a vaginal delivery in an optimal way as possible to minimize the chance of tearing, to minimize the chance of having any kind of a prolapse, using positions sometimes people suggest avoiding an epidural can be helpful, but I would absolutely not make that as a blanket recommendation. I think that's an individual thing that women could explore a little bit further. But the physical pressure should not worsen your MS.
Thank you. Somebody has said, great to know which medications can be used during pregnancy, if only for part of it. But they've been stable for a couple of years now, and would it be best to come off all medicines, even if they're on one of the medicines that can be used?
I think that's a difficult question to answer without me sitting with somebody's medical records, because somebody might be on a really good medication and they might have been stable for 7 or 8 years and they might be doing absolutely great. But I might look back and go, well, actually, though, when they were diagnosed first, they had 3 pretty serious relapses within the first year before they went on to this medication. And then they went on to medication and done really well. But someone like that, I would be very, very slow to tell them to stop their medication.
Okay.
Sclerosis, so that's why I'd be nervous about that.
Perfect. And one final question, I'm just conscious of time now. If your MS isn't stable, so you said, like, so people, you know, typically they would come and talk to you maybe about a year in advance, let's say.
Yes.
But if in that year in advance their MS hasn't been stable, would that hinder, you know, their plan? Or like, would you be recommending that they stabilize their MS before pregnancy, or what would be the
Yeah, ideally, but that would be a very individual thing. So say, for example, and again, it's why it's hard to answer for, you know, everyone. However, say if somebody was 39 and they had a scan within the last year that showed a couple of new lesions, but they really wanted to plan their first pregnancy. So for that person, we wouldn't necessarily want to tell them to wait a year or 2 to get on top of the MS, because time isn't necessarily on their side. So we'd look and see what we could do, and we'd probably recommend being on a treatment at least up until conception, and potentially for a period of time during the pregnancy as well. So it doesn't necessarily mean don't, but if you're 27 or 28, you've no fertility concerns, there's no reason not to wait a few months. We probably would say, look, let's just get on top of things, get you in a very nice clear path so that you can go ahead and enjoy the pregnancy without and the postpartum period without any anxieties at all.
Really covering the whole spectrum of pregnancy, breastfeeding, contraception, fertility, everything. And we really appreciate it.